Okay, well, thank you so much for the privilege of your podium today. I'm going to ask for a little bit of grace because I'm absolutely terrified of public speaking. And it's been a while since COVID, but when Big Man asked me to give a talk, and then Dr. Fellows calls and says, Jess, you got to give this talk. Those are two people you absolutely never say no to. So I'm here and I'm dying inside. So if I stumble a bit, please help me out. So my name is Jessica Pierce, and I am the medical director of the wound program at VM. I started the program a little over 11, 12 years ago, and we've been going ever since. It is something that I absolutely love. So if I totally dork out up here, I am sorry. Please feel free to take my information down and call me about any patient you have. These patients are so hard. I also want to put it out there that if you have patients you are concerned about, I'm always there for a phone a friend. If any of your nurses or team members, home health, anybody, if you guys want to come and rotate with us in my clinic with me, I've had people over the years that I've been fortunate enough to meet at this conference who have either sent their staff or they've come over and spent some time in our clinic, and I welcome it. We're only as strong as our weakest link, and these patients are so difficult. We are in the process of getting licenses around in the surrounding states at VM, and so that's another option we have for the tele visits, that we can really utilize our eyes and ears in the field with our home health and our other support services. So it's really impactful work, and it's the right work. It's not necessarily the easiest work, but it's good stuff. So the goals of my talk today are going to be basically just reviewing basic principles and concepts, and then understanding the different modalities that we use in this group of patients. I have no disclosures, lots of opinions. So this is the 4 normal parts of wound healing, and we've all seen this slide in one, variation or another. And basically, my patients never go through this, okay? They always miss some important step here. And basically, we call a wound an ulcer after about 3 weeks. So if you see do I have a little, I do. This over here, this part, it's about 21 days. Sometimes we'll give you a little bit more, sometimes a little less, but after about 21 days, we call it an ulcer. Now, nobody ever really wants to go to the ulcer clinic because they think they're going to go get a scope of some sort for their intestines, right? Or a stomach ulcer. So we call it a wound center. And we interchange wound and ulcer quite a bit. And I am very guilty of doing that. So again, a wound becomes an ulcer after about 3 weeks. So when we learn about wounds, we learn about them in different buckets. And for the purposes of learning about these things, I'm going to put them in different buckets, okay? Now, venous, arterial, diabetic, and pressure. I could give an entire weekend's conference if I didn't die of a heart attack and embarrassment and anxiety before that. About pressure. So I'm not really going to touch on pressure, but I will say it is a CMS never event for patients that are in the hospital. Okay, so as providers, as practitioners, as anybody who touches a patient, if you are in the outpatient setting and you see somebody with a pressure ulcer, please put it in their problem list, in their formal problem list that follows them throughout, because the second they hit the door of a hospital, they will get put on surfaces, they will get, different things for them to prevent. And also it protects your institution from medical legal nightmares. So this is a slide that we have all seen. And for completeness sake, I'm putting it in here. And again, it's venous, arterial, diabetic, and pressure. And this is probably on every EMR. It's somewhere in there that you can just click on it, and it kind of gives you this snapshot of, what the condition is, where they usually are located, and how you treat it in that nice, neat little box below. So I'm going to start with the venous ulcers, and that's basically because this is going to be a tremendous amount of the patients that we're going to be seeing in the clinic. This slide has the ultrasound over here. Get it. Where the red is basically showing the blood going retrograde. So it's not actually going through in the right direction. Okay, so hence the name reflux. These take forever to heal. They are horrible. I tell patients that these are like giant parasites on your body. They are painful. They are cumbersome. They are smelly. They are life robbing, meaning your quality of life is horrible. The amount of drainage alone is so significant. I mean, they have to change their sheets every day. They have to, just the quality of life is horrible. We actually see a ton of clinical depression with these patients and a significant amount of malnourishment. So they just feel awful. So we can really intervene in a meaningful way in this group of patients. But we have to make sure that, this is exactly what we're dealing with. So basically with venous insufficiency is the way I like to describe it to patients is your heart pumps, and it pumps a wave of blood through the arteries into the tip of the toe, turns the corner, and comes back up through the veins. And the veins are made up of a series of one-way valves. And so every time your heart pushes that wave of blood through, there is like a submarine door that snaps together behind it and keeps the blood up from gravity, from falling to the ground. And if something is wrong with that valve because of genetics or trauma or, bad luck, all of that blood then falls to the bottom. And the way I describe it to patients is that it's kind of like this should be the wall of your vein. And when they get so engorged because the valves haven't kept that blood up and, moving in that right direction, they become fat and juicy worms that leak through the sidewalls. So now you have fluid leaking through those sidewalls. And it's kind of like condensation on the outside of a glass. Okay, and we've all had this happen where it leaves that ring of fluid on the bottom of the table. Well, that's what happens with venous disease. And so our patients' legs will swell and shrink and swell and shrink. And all of that juice that has leaked out of those veins now is bathing their muscles and their nerves in fluid that basically is like battery acid. So when you get a wound, all of a sudden, instead of staying in those tissues, now you have a pop-off valve, okay? And you have somewhere for that fluid to go. So it starts up high and it drip, 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 all the way down their leg. And so these wounds will often start up and they move down. So it's important because the second you remove gravity, all of a sudden you remove the need for the valve. So when they put their legs up at night, their legs shrink down. And guess what? They all have to get up and go pee in the middle of the night multiple times. And those of us who stand for any length of time know that. I have my compression hose on right now. I hope you do too. But if I don't wear my compression hose, guess what? I'm up peeing all night long. And guess where the most dangerous place to fall is? The bathroom or your kitchen. And so when our patients get up to go pee in the middle of the night, that's when they fall, and that's when they break their hip, their shoulders, their arms, whatever. And so just by recognizing this process in our patient population, you can prevent, you know, a lot of morbidity associated with wound patients in general. Okay, so again, these are just a lot of this stuff is in here just for completeness sake, but you know, these are my people. This is a great classification of the you know, you can even see on some of them the wrinkles in their skin from a wrap. But also remember that the hemosiderin staining, the way I tell patients is that it's like iron, it's like rust in your skin, and it can cause really itchy legs. And so one of the things that I see a lot is patients who go down to scratch their legs for venous disease, and they end up actually making wounds in their skin that we then have to address. So gold standard for this is to order a venous reflux study. And basically they're looking for reflux in the greater saphenous or lesser saphenous. You have to specify a reflux study, because if you do not, you will get a rule out DVT, and that's a totally different study, okay? So the next bucket that we're gonna talk about is arterial ulcers. And, you know, these are horribly painful. They're the shallow, punched out, pale ulcers. Typically, you'll have a skinny little patient that smells like smoke coming in, you know. They typically will dangle their foot off the side of the exam bed. You know, you pretty much can smell the cigarette smoke before you go in to see them, that type of thing. They're horribly, horribly painful for patients. And they have that pale wound bed. They hardly bleed, usually eschlerotic, and typically in between the toes and on the foot. This is a angiogram of just that pinched off area. So best way to assess, again, for the diagnosis of this is ABI. And we've all done these in one form or another in our offices, pretty standard. The normal is 0.9 to about 1.3, but again, this can also be falsely elevated, especially in diabetics if they have non-compressible vessels. So if you get this year after year and you notice that it's going up, that's actually not a good sign, okay? So that means that their vessels are getting more rigid, more non-compressible, disease process is exacerbated. Now, this is my favorite part of this study, and that is the ABI with waveform. Way I explain this to patients is this is when your heart beats and that wave of blood that goes through your vessels, this is what it looks like. I am not a cardiologist. I don't pretend to be a cardiologist, and I really am kind of terrified of cardiac patients. I like my EKGs nice and bumpy, and that's how I like my waveforms, okay? Nice and bumpy. You can see the one in black. It's pretty much a flat line. Well, that really, like an EKG, is not very compatible with life, nor is it compatible with viable legs, okay? So again, we can tell based on the way the blood flows through. It's basically like a pulse ox we put on the toes while they're doing the ABI, and it has to be done in a vascular lab, but this gives us a tremendous amount of information, because even if your ABIs are abnormal and you have good waveforms, you're gonna be okay, all right? And so we just follow the waveforms. It's like my favorite trick. So we used to not be able to get any decent imaging below the knee. And as a result, we couldn't intervene. It was kind of like, okay, let's keep our fingers crossed. You know, what are you gonna do? Well, now we can, okay? And not only can we get imaging that's decent, we can actually intervene. We can get little bitty wires and catheters in the dorsal aspect of the foot. And so instead of just coming down from the groin or the wrist, we can hit it from both sides. And that is slick. It's a game changer for a lot of patients, because that's the difference of having a perfused foot and a non-perfused foot. Okay, so the main ones I want you to look at are the anterior tibial, the posterior tibial, and the perineal arteries, okay, in the anterior and posterior view. We all know how to feel for a DP pulse and a PT pulse, but perineal, how are you going to feel for that? Okay. Well, the same way we have dermatomes for our nerves, we have angiosomes for our arteries. Okay. And the angiosomes for the arteries are, again, in that distribution path of the vessel that is feeding that area. Okay, so this is super important for our patients because just because they have a palpable pulse doesn't necessarily mean that they are perfused enough to heal their wound. Now, with my non-existent computer skills, I tried to cut and paste several of these different things on here to kind of put them side by side. But again, this kind of just put it all together in one page of where the angiosomes are and the actual arteries of the different areas that are being perfused by these vessels. Okay, and again, remember, we used to just cut legs off, right? Now we can actually go in, revascularize that vessel so that we can get blood flow to the area. If there's an infection and you give somebody antibiotics are in the blood. How's the antibiotic going to get there? How is it going to get the building blocks to heal that tissue in? Okay, so we've got to get perfusion first and foremost. So again, this is a wound on the top of a guy's foot. Turns out he has an AT that's out. We go in, we revasc it. They can do an orbital atherectomy where they actually take it and roto-rooter it out. Sometimes that's enough. Sometimes we have to do a stent. They use cardiac stents quite a bit in the leg. And then again, also, I actually told my patient on Tuesday this, arterial disease is like a really bad case of herpes, okay? It never goes away. Okay, it always, just when you think you've gotten rid of it, right? It comes back up. So you always have to interrogate these patients, okay? And if your patient is healed and then they come back in, they have a new wound, recheck it. Just because they've gotten treated, it doesn't last forever. All right, can you hear me? Okay, so now onto diabetic foot ulcers. Again, offload them and put topical growth factors. Well, if they have blood flow, topical growth factor, that is actually everything you need is in the blood, okay? Offloading it, that is wonderful. However, whoever is writing for the diabetic medicines must write for the diabetic footwear. Otherwise, they will not take your prescription, and you've just delayed getting your patient the appropriate footwear. So footwear is for prevention, because that's going to be the best way to treat these, unfortunately. Now, more than 90% of patients with diabetes have peripheral neuropathy, and they don't even realize that they've got it, okay? So again, this is just for more completeness than anything. I cannot give a talk without putting this slide in because it's in every wound lecture or conference I've ever been to, talking about the mortality rates, which are tremendous in all comers to our wound centers. So the other thing about the diabetic population that we serve is 50% of these patients are gonna have PAD. Now you combine that with the neuropathy, and they are not going to give you the classic symptoms of, oh, when I walk to your clinic, my leg is killing me, my foot is killing me, I have claudication. They never give me that. And boy, I wish they would. They never offer up that because they don't feel it. And so it's a really tricky spot we're in because we have to be very aggressive when it comes to the identification of any type of wound or PAD or compromised tissue in our diabetic population, because they frankly will not feel it by the time they see it or somebody sees it. Cat's going to be out of the bag, and they're coming in because their dog is either going crazy with their wound, sniffing it, or bones are coming out of their foot, or they're getting hung up, the little tufts of their bones are getting hung up on the carpet as they walk to the bathroom. And this is, I see it 2 or 3 times a week. And so we have to be very, very proactive when it comes to recognizing this problem in our diabetics. This is one of the newer studies that came out. I normally tell patients blood glucose of 180 or under because the cells can't divide. The mitotic spindles don't really work well at over 180. This study just came out of fasting glucose of 126 and an A1C under 8. So that's kind of my new jam, my new little speech I give them. So again, the expectation is nice, neat little buckets. That is never my reality, okay? I wish it was. My patients have all of these all at once, all the time. So here's our diabetic foot. And so, you know, we can't just say, okay, this is a diabetic foot ulcer. We're gonna offload it and it's gonna get better, because there's more than one. One problem does not exclude or does not preclude the others. So this patient actually had a posterior tibial that was out. So it wasn't just enough to get the sugars under control and to offload. We actually had to go back in and have him revasc to restore inline flow down to the foot so that they're able to heal. And that's the classic mixed ulcer, that's what we call a mixed ulcer. And again, more and more, this number says 26%. I think it's a lot higher than that. So again, it's where you have both arterial and venous. Dominant process must be treated first. And again, if you have a venous ulcer, you cannot compress without ensuring that you have appropriate arterial blood flow, because then you've just put a giant tourniquet on the ischemic extremity. So we really need to make sure that they can tolerate the compression. So this is something I presented a few years ago, maybe right before COVID, I think. And this is something that we are seeing more and more. And I wanted to make sure that you guys know and are aware of this. These are actually needle fragments in bodies. And can I get a show of hands of how many people treat IV drug users or, yeah. So, and it's becoming more and more prevalent. So this is a needle tip, and I don't know if y'all have seen this photograph before or not, but you know, these needles are only meant to be used once. And they're being used over and over and over again. And they're being used in scarred tissue that is hard as a rock. And they're breaking off. Now, pieces of metal or metal fragments in and of themselves are not dangerous to have in your body, okay? We have surgery staples, we have, you know, breast biopsy markers, we have all sorts of stuff, okay? That isn't necessarily dangerous. When it becomes dangerous is when we're doing this, okay? We had 25 needle tips in one abscess. And they're cutting the drugs with different things that are making abscesses, that are forming abscesses that's clearly less than sterile conditions when they're injecting. And so they're getting this patient population is getting abscess formation. So stuff like this terrifies me, because if you have a giant pocket of pus, the viral load in that pocket of pus is tremendous. And now we are squeezing on it. We're having purulent fluid come out. We are probing it. We are having usually, some poor intern or new nurse go in and pack the wound itself and then pull it out and grab that wad up as tight as we can in our hand and, pull our glove over it to throw it away. I mean, oh my gosh, right? And just think about it, it's a wad of needles. So the literature it's non-existent. Most of it's from coroner's reports of the coroners getting stuck after the patients are dead. So we were seeing so much of this in our downtown clinic and in our downtown in the hospital that I came up with this protocol, and feel free to take it, use it, do whatever you want with it, throw it away. But this is what we use in my clinic. And basically it is a way to keep our staff safe and to keep ourselves safe, and to also let this patient population know exactly what we're doing, completely transparent about it. So one of the things that, throughout the course of treating IV drug users, they always have one area that they really like to shoot. Oftentimes it's, here or, a particular arm. Depending on the depth that they need, the needles will be bigger or shorter. So kind of just being very upfront and asking, saying, hey, where's your favorite place to shoot? And you'd be surprised, they will always tell you. And then get an x-ray. Get an x-ray first and foremost. And put on their rule out foreign body. And I tell our patients, I say, look, I don't want to get stuck with the needle fragment that's in your body, because that really sucks. So we're going to get an x-ray just to make sure we're safe. Okay. And they're all very okay with it, surprisingly. The other thing is that we really try to limit the people that are in our rooms with us, because if you have more people in and out, like I'm a freak with sharps, like I do not like anybody else throwing away my sharps. I like to handle my sharps. So we really try to limit the people that are in there and then the number of sharps that we have out. So again, we'll touch back on this in a little bit, but feel free to take it, use it, throw it away, whatever. But this is how we handle this. And also double glove with this group of patients, just because it's harder to make it through 2 gloves than it is 1. So how to treat? Treat the underlying disease. Post-COVID, patients are coming in, disasters. And I don't need to tell anybody in this room, it's a different world out there now. We are seeing more advanced disease. We are treating things on the floors that we used to treat in the unit. We are treating things in the clinic that we used to treat in the hospital. We're treating things at home health that used to only be seen in specialty clinics. It's real. And then the supply chain stuff, another hat I wear is I'm the advanced wound care physician champion for all of Common Spirit for our national organization. And supplies, we're all facing this across the board. Supplies are very hard to come by and they're very expensive. And just when you get the right thing, it changes. So this is a very common problem, but underlying all of it is treat the disease. Treat the underlying issue. And we only can do that by identifying what those issues are. And then manage them to the best of your ability. So our patients with the lower extremity ulcers, we get vascular studies on all of them. And we do the ABI with waveform, and we do the reflux ultrasound. Again, this is in here for completeness sake, but again, it's managing the mixed lower extremity ulceration in patients. If you do need to start compression on a patient, please, please, please start slow and go very low with your compression. Please do not give patients a compression hose that's this big around and ask them to put it on with their RA fingers that they can't wear, that they can't use. It's pointless. They're never going to use it, and they're going to spend $80 on a stocking that will just clog their drawers. We oftentimes will use like the elastic tubes or Tubigrip. Start low. That's better than nothing. The other thing, if you have an open ulcer, Medicare will reimburse for circ aids, and you can order those from wound supply companies, which are actually Velcro on, and you can wash them in the washing machine. So, start low and go really, really slow. A little is better than nothing at all. So this is how I learn the best. So cases, so again, when I look at this leg or this ankle, I think, oh, that is a really kind of gnarly venous ulcer. They have lots of dry skin, so they've been kind of doing that snake skin thing, swelling and shrinking, swelling and shrinking. It doesn't look too terribly bad, but that looks like it's very itchy, those edges. So first thing I would do is use some moisturizer like CeraVe. I ask my patients to scrub their fingernails and file them down because they will shred their legs and give themselves wounds. And oftentimes you can actually find the paw print of their hand on their leg, cover it with an ABD. And then this is that tubular stocking I was talking about. It's very low compression. It's easy to get on and off. You can put it in the washing machine. You can cut new ones for them every time they come in. And again, it's not a whole lot, but it's just enough. So case 2, again, this is that kind of no man's land in the perineal artery. So again, you're not going to feel, even if this patient has bounding pulses, if somebody says that's not an arterial ulcer, I'm going to have a problem with that. That's actually why they call me the pit bull in pearls, because I never, at work, I never accept it. I'm like, no, they need this, that, and the other. So keep fighting for your patient if you think that, if somebody tells you this isn't arterial, because I beg to differ. It's arterial until proven otherwise. So keep fighting for those patients. The best way to treat an eschar is basically keep it on there as long as you can, keep it dry. So silver nitrate around the outside. It's a chemical cautery agent, but it's also an escharotic agent. And so oftentimes, like in the note, I'll say silver nitrate used for its escharotic properties. It kills the bacteria, it stabilizes those kind of juicy little edges, and then paint it with betadine, keep it dry, 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 dry. I also see this leg as a kind of a doughy leg, and they probably have some venous or some lymphatic congestion there, but again, we wouldn't necessarily want to put them in any type of compression until we know. So I'll have patients do calf pump exercises, so write the ABCs with their toes, and nose to toes, to where you remove the gravity, and so it's kind of like body's a pan of water, and so it can get back up to your heart and your thoracic duct for your lymphatic system. Case number 3, again, that's going to be straight up arterial until proven otherwise. And I want you to think about the arteries when they come in for those angiosums, those watershed areas where you get a little bit of flow from one side and a little bit of flow from another, but you don't get real robust flow from one bigger vessel. And so when you have something that's going to attack your arteries in those small vessels, you kind of get this dead zone. And that is classic in between your toes. Okay, that's why everyone's always looking in between toes. And in these areas like that, the heel is another great spot where you just don't get that robust, those bigger arteries to supplement any of that. So for this wound, I would use something antimicrobial because it's on a foot. And then I would just cover it and protect it until, we can get arterial status confirmed, and make sure that, and you can also tell this patient, again, has some venous disease just by the spider telangiectasias there. And back to our IV drug use. Again, you see an arm like this and they have a wound on their arm. X-ray, X-ray, X-ray. This is one of our tricks that we use in our clinic is these green things, and they have them, they're not really instruments. They're used in the OR to clip they're towel clips. So they're used to clip the drape up and to clip just different things over the patient and around the patient. They are disposable. Every single hospital will have these in one version or another. And they are awesome, awesome, awesome. You can use them in so many different ways, but what we like to use them for is chip clips. And then to get it 4x4, roll it up in there, and you can use that for hemostasis if they are bleeding, because oftentimes they have no ability to coagulate because their liver's gone, okay? And then also, if there is an abscess that you're having to get anything out or to clean the wound with, use this. Do not use your fingers, please, please, please. Also, if we are scrubbing down a wound, we'll use like a surgery scrub brush or this to clean it up. And so it just is one more layer between you and potential needle fragments that could certainly cause a problem. The other thing is Xeriform. Xeriform is wonderful in these patients and on these wounds. It is, for some reason, it is so wonderful for their pain. Patients that have used a lot of opioids, it's like they have a post-opioid hyperanalgesia where you just cannot get them comfortable. And Xeriform is wonderful in helping with that. And again, for whatever reason, I have tried everything, and this is my favorite. It comes in giant sheets. It's cheap. You can send a bunch out with them, and it's not going to break the bank. And it's easy to take on and off, and it prevents just the skin around it from getting really agitated. And then we use ABD pads and roll gauze and wash with betadine. So those are my favorites for this type of wound. And that's it. Do y'all have any questions? Questions?
Oh, good afternoon. It's so good to have you here. I'm Dr. Olympia Stafford, formerly Takapulu in Tacoma. So, and we shared so many patients over the years.
We're awesome. I'm so glad to meet you in person.
And I still remember the one case that we had, a patient with a spine hardware infection, where the infection we lost tissue all the way down to the bone. And I think we didn't know what to do with her because you could see the spine.
Yeah.
And I remember you end up using maggots for her to eat all the devitalized tissue.
Yeah.
And that lady did well. She actually healed completely. And I was so amazed by what you did. And of course, over the years, there were so many patients that you took care of for us. That was so awesome. So I have a question. What's your take on hyperbaric oxygen? What do you think? What's the best way to use it?
I love hyperbaric. So I actually opened a wound center when I was first recruited to Washington State in Grays Harbor. And I was fortunate enough to learn wound care during my residency program. So I'm very hyper, and I did it. I got done with all of my required procedures and all that within like the first 9 months. And we were the only residents in the hospital, code pager, full L&D department, 22-bed ICU. And I just was busy. If I was going to live there, I was going to be busy. And so when we opened there, the medical director in Texas said, "You're kind of crazy and you're here all the time. If I have to go in for a AAA, can you cover my clinic? But I need you to get certified in hyperbarics." And so I did. They gave me a scholarship and I went. And I was able to do 2 longitudinal years with inpatient, outpatient, and all the different subspecialties in this clinic. And I really got to see how different specialties used hyperbarics, and not everybody uses it the same. There is a definite learning curve with hyperbarics, and there's patients who excel with it. But when I got to Grace Harbor, they didn't have it. So I put in 2 chambers. And it is wonderful for the right patient. Radiation, no brainer. I had patients that would come in and say, I'm going to kill myself because I can't stand this anymore. I can't. And I'd say, I will help you figure this out, this killing yourself part, but you got to give me a chance to heal you first. And literally within like 10 dives, all of their symptoms had gone away. And it was heartbreaking when I left there, because I had this whole group of patients who would bring me flowers every, 2 months or stuff, like just like daffodils or whatever was blooming in their house, because they were still alive. Okay, so it works, and it is amazing for radiation. And if you learn one thing from me today is, don't put your hand in a shooter's abscess without getting an x-ray. And number 2, hyperbarics is amazing for radiation. That said, it is really hard to get covered. And so for things like diabetic foot ulcers, yes, it works. It is a commitment. It's 2 to 3 hours a day, every day, 5 days a week. And if they're not willing to do that, it doesn't work, because it stacks, it builds on itself. But for the right patient, it is awesome. Awesome. Yeah, I mean, it's, and maggots, I have to be careful because I don't want to be known as maggot girl. But maggots are, they're grown at a UC Irvine, and there is a Monarch Labs there. They have the green bottle fly, and they have been in captivity with the same, it's a husband and wife team. And so I've called, and she's like, well, hold on, he just went to pick up the kids. Let me connect you to his cell phone. I mean, like, they're so nice. And they've had this same strain for 20 plus years, and they overnight it to you. And they actually have to not put on the box what is in there, because the postal workers would not carry them. And if you send them, I always, it's kind of inappropriate, but sorry. It's Friday at the end of the day. No, it's like you're receiving porn at your office, because you keep going to the office, like where all the mail comes in. You're like, did my package get here? Did my package get here? And it's like in this very unmarked box, like, and everyone's asking about it. And like, anyway, so it's really neat. There are maggots that eat live tissue, and there's maggots that eat only dead tissue. The green bottle fly only eats dead tissue. And actually the maggots were really the gold standard until penicillin came out. And then when penicillin came out, nobody wanted maggots anymore, right? And so we all switched to using penicillin. But guess what? Maggots work better sometimes than that, because they can get into all those little nooks and crannies. And then their saliva has a multi-drug resistant, it works on these things. And so if they can get their mouth around it, they can chew it down. So like, we have saved flaps, we've saved hardware. I mean, you and I together have done this, and it is so cool. So we can actually prevent a ton of pain and suffering and just horrible outcomes with maggots. And if they're willing to do it, it is awesome, awesome, awesome. It really is kind of slick. It's just getting over it, and you put them on, you build a cage around it, and they just have to change the top layer of gauze. However often, they need to for a couple of days. And worst case scenario, they go in the backyard and wash them off with a hose if they can't tolerate it, and put a piece of gauze on over it and come back in. So it's, but again, I have to be kind of careful who I talk to this about. And typically they always want me to give a lecture over lunchtime about maggots or wounds, and it's very hard. So, any other questions?
Hi, I'm Jessica Roberts. I'm a third-year family medicine resident.
Yay!
I am curious about your thoughts on using topical corticosteroids for patients that have itching related to venous stasis ulcers,
Mhm.
or if they may not have an ulcer developed yet, because my fear is like thinning the skin with the
I love it.
corticosteroid and then increasing their already sensitive skin. Is that a fair assumption?
I love it. I love me some steroids. Um, so, you know, so here's my, I use a ton of stuff off label, because the normal things haven't worked for my patients. So I have to recreate or reinvent things for them, because the standard treatment hasn't worked. And if you have someone who is scratching their leg, like that one photo, literally claw marks on their legs, and putting some steroid on them is going to prevent that, just do it. I mean, you know, you shouldn't do it for, a decade, but yeah, if they need it, they need it. I mean, I use topical lidocaine on my patients all the time, and it says, don't put it on a wound. Well, what the hell am I going to put it on? I mean, they need a little bit of something, right? So I actually will also use lidocaine, and I'll mix a little slurry of lidocaine and topical steroid. And if that gets their fingers off of it, you win, until they can get that, moisturized, and until they can get actually a little touch of compression in those patients goes a long way to reducing that. It's venous eczema is what it is. And it's from that swelling, shrinking, and that hemosiderin that kind of leaks out of the sidewall that bathes all that stuff. It's really itchy. CeraVe is really good for that. And so is Sarna, and they have an anti-itch one that's fantastic. But sometimes you have to, so I'll get a surgery scrub brush and I'll scrub all the crusties off them. I'm a total picker. So I'll get all that off of them, and then I'll use the CeraVe or, some sort of lotion, not Lubriderm. Everybody wants to use Lubriderm. It drives me crazy. But something that you can turn it upside down and it won't fall out of the jar. Our male patients really have a problem accepting that, using like lotions and stuff. And so I'll just tell their wives, or their spouses or kids, whatever, you've got to have this moisturized, because if not, it's going to be really super itchy. But again, surgery scrub brush or some sort of scrub brush underneath the fingernails, and then filing them down to nubs so that they can't get purchase on that skin and just scratch it right open.
Yeah, Dr. Chua here. Questions. Use of coconut oil
Love it.
and also the use of Medihoney. What's your experience on those?
So I think I was the first person in Washington State to use Medihoney. And it's leptospirum. It's from a special pollen from New Zealand, but it's wonderful. And actually veterinarians will use, so they tell me, will use Manuka honey from Whole Foods. And the way it works is it pulls it changes the osmotic gradient, and so it will change the pH. And so it's wonderful. I love Medihoney for that. It covers so many different things. And what I really love it for is patients who have like tumors, anywhere from like here up. It is wonderful. So in that group of patients, and I see a lot of breast cancer patients, they have a smell to their wound that they cannot get past, and the Medihoney gets rid of it. And it is amazing. For whatever reason, and it will gently like debride it. It can get kind of gooey, but it's wonderful. Yeah, I love it. I love it. And one of the tricks I did with actually my son was they have different percentages of the leptospirum honey. And so it doesn't taste good, like at the 85%, 85%. But they have a higher percentage that's like, I want to say it's like 100 or 95%. It's almost like the crystals on the bottom of the old honey jars. And because it will pull that fluid out, almost like a saltwater gargle, I would put it on my son's teeth when he was teething. And you want to talk about working quickly and beautifully, it just pulls all that red inflammation out. It's awesome. So for whatever it's worth, I love it. I use it on my kid. I have it in our baseball team's, medical kit, medical bag. And it's just kind of nice. Coconut oil, love it. I use a lot of coconut oil and I use a lot of mineral oil, actually. We know that about 3 centimeters outside of the actual wound bed, the healthier that skin is, the faster the wound will heal. And I don't trust any studies because I can make any set of numbers say what I want it to if you just manipulate the data, right? So I am very persnickety when it comes to product. I also know that the majority of the wound studies are done by industry. And if someone's trying to sell me something, I kind of have a problem with taking blind faith in that. So I try every bandage, I try every dressing. You can think of every lotion, every cream, you name it, I've tried it if I'm going to recommend it for my patients. And so the mineral oil is a good one. The Meta honey is a good one. The coconut, some people can't stand the smell. So that's the only problem I've had with that. But absolutely, absolutely. Especially like if they've used it their whole lives. Absolutely. And they want to use it, of course. Of course. And then if we want to put a dressing on, I'll just have them, they know that I'm just going to use an alcohol wipe or something around it and then put the, adhesive foam on there and then go around it.
Oh, okay, there we go. So in our area, we've had a couple cases of pyoderma and conflicting opinions on it. So I'm just curious to know what your opinion on treatment for pyoderma.
Oh, that's a loaded question. If it is truly pyoderma, yikes, right? If it's not, every once in a while, like I get like a wave of like 6 patients with pyoderma. And I'm like, was there just a conference that talked about pyoderma? Because everybody has pyoderma right now. And, is it or isn't it? And, I think the underlying principles of wound care still apply, right? So if they have a wound and you know that they're gonna need building blocks and substrate to heal the wound, well then, okay, let's get the arterial study. Let's get the, they can have more than one process going on, right? They're horribly painful. So just looking at them sideways, they're like, what? Honey has been wonderful for some of our pyoderma patients. Actually, sometimes if I don't believe it, I'll say, okay, I'm going to debride this because it's covered in nasty dead goo that's a petri dish. It may get 10 times bigger. It may not. If it gets 10 times bigger, we got your diagnosis. People get mad at me when I do that, but when they come back in the next visit and it's half the size and it doesn't smell anymore and it's better, then it's kind of, so I think it's a scary diagnosis. And I kind of answered, it's a loaded question a little bit. I think it kind of depends. For the patients that I've seen with true pyoderma, they are so uncomfortable. It's almost like you can see them and know what they've got when they come in.
I'd like to add a couple of things about coconut oil that was mentioned here just a bit ago. Coconut oil, to back up a little bit, coconut oil is excellent on sensitive skin. The incidence of sensitive skin in the general population, believe it or not, is up to 43%. That means over 4 out of every 10 people wandering around Tri-Cities has sensitive skin to some degree. There's a spectrum. And sensitive skin generally needs something that is ideally pure, natural, organic, has no additional chemicals. is edible and cheap. Coconut oil fits this beautifully for one other reason. When God made skin, he made skin at a mild acid pH of 4.5 to 5.5. All of the soaps are basic. They tend to keep skin in a basic pH. The standard soaps run between 9 and 13, the gentle ones between 8 and 10. All of this makes the skin more vulnerable. The beauty of coconut oil is it's a mild acid. It's about almost 50% lauric acid. And the lauric acid, because coconut oil is so gentle and it's cheap. I like things that are cheap. What I call the KISS approach, keep it simply simple. And so then using coconut oil is inexpensive. The key is, as I had mentioned earlier, in the use of ointments rather than creams. Ointments do a better job of protecting, providing it's added to damp skin. So coconut oil is an ideal one, and it's cheap. I like things that are cheap and good.
Can you hear me? Okay. Dr. Marsalo, internal medicine. Just like to ask your comments. I have just two questions, if you don't mind. I have some patients who have the ulcers and, they don't want to use any opioids for pain. How about a comment on using CBD as a topical agent for that? And then the other ones, do you have any experience concerning medicinal leeches in chronic ulcers? Thank you.
So I have had, because VM does not, we get Medicare funding, so we can't really come out and say that in regards to those products. I will say that I have several patients who currently use that. They love it. And it is the only way to achieve any sort of relief for them. And if that's what they need, that's what they need. I think it's a wonderful, frankly, I've told patients I would rather use that than, OxyContin, right? I think if you have someone who's very knowledgeable, I think it's wonderful. And I can't come out and document it and say it and all that because of Virginia Mason. And, but I think that I've had several patients who have had wonderful success with that. Another cheap, easy trick is black tea bags in the refrigerator as cold compresses on wounds. It's amazing. For some of our pyoderma patients, the black tea bags with as a cold compress, the antioxidants in them, the anti-inflammatory, it's amazing. So again, keeping it simple, that's another great modality. But if that's what they need, then that's what they need. Being in Grace Harbor, we had a tremendous amount of addiction there. And because my training, I can do from womb to tomb, and I do a lot of pediatric wounds. Not so much currently, but I had a rule across the board where I won't prescribe narcotics in my clinic because I was seeing so many abused kids and vulnerable patients that were coming in to see me because they thought I would write for narcotics for the wounds and for debridements. And so now across the board, it's a no-go. And I actually made it a policy in our clinic. They have to go through their primary or a pain management clinic because that's a totally different situation. We use topical lidocaine, liquid or cream, and then I'll wash their legs. I will put it on the wound, and then I'll put a heat pack on top so that they can vasodilate. and actually get some penetration of that. Another thing that potentially you can do, depending on your office, location, you can use topical morphine. And this has been done in some small studies in the hospice population. And again, it gets those mu receptors. And so sometimes lidocaine isn't enough. And so you can get a different receptor with the topical morphine, and you can, titrate it as you want, usually like 2 morphine to say 10 mLs of lidocaine, and put it on and then let it soak in. Mostly it's the edges of the wounds that are so painful. And again, the deeper the wounds, they have different pain receptors than the surface of them. Remember, you can do 2-point discrimination on your skin. And so that's mostly the area that we'll focus on. I have patients use the topical lidocaine and then they can put it on before they come in. Sometimes that helps. If you're using a wound vac, disconnect the wound vac before you pull the sponge and all that out. You can inject the wound vac with lidocaine and then follow it with the flush so that the whole entire wound bed is bathed with lidocaine. And again, these are things that we do all the time. We just kind of forget, that other people don't do this normally. And so it really shouldn't hurt. It can be uncomfortable, but it shouldn't hurt that badly. And so if there's something else going on and pain levels are uncontrollable, then we'll have them go to the, OR, or we'll have, a different type of dressing used so that it's not, that uncomfortable for them.
Can you hear me?
Yeah.
I'm Catherine Donaldson from Walla Walla. My question is, using oral supplementary collagen to strengthen tissue integrity from the inside out. Have you ever done that for wound care?
I have. We have had several patients utilize that. It's really expensive. And Medicare will cover nutrition if you have renal disease and if you have diabetes. So I like to get our nutritionist on board for those. I think they cover 2 visits a year if you have one of those diagnoses. That said, I always like to get them involved. If they're admitted to the hospital, I always try to get that nutrition consult in so that they can help guide me, because I don't want to tell them to get something and use it, and then have them break the bank with that. So I like things that have, we have a list, and I like things that have a little bit, not just the collagen in there, that have different, vitamins and minerals that they can also benefit from. If you remember, prealbumin is a great marker, right? And I think of prealbumin like a glucose versus albumin like an A1C. So prealbumin and albumin are actually not related. Prealbumin gels out on electrophoresis before albumin does. Okay, so just because someone's prealbumin is, they're not related. They just gel out one before the other. So I try to get, my favorite actually is Premier Protein at Costco, because they can go buy a giant case of it. You can get Premier Protein delivered on Amazon. That's the multi-pack flavor. And I know for people who want, additional things, that's not for them. But for the most part, cheap and effective, they're great. Or Ensures, I tell patients to put it in a martini shaker, shake it up, put whipped cream on top, because whipped cream has a ton of protein in it. And then get a great big fat giant straw and go to town. Put a little bit of cinnamon on top, because cinnamon is actually anti-inflammatory. I also tell my patients to have a great big old glass of red wine. It's good for you, being from Texas and growing up on a cattle ranch, I tell patients, eat meat. Yeah, these pointy teeth right here, that's what they're for, being in Seattle, sometimes that kind of offended people. But if they can't do that, We need to figure out how to supplement in other ways. And again, if you think about these giant venous ulcers, okay, think about the fluid that comes out of them. And we've all had these patients come in where they drip, 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 you know, they leave like the slime trail behind you. And you're like, oh my gosh, that is like unbelievable how much they're draining. And that they have to drink that in order to excrete, like have it come out of their wound. Imagine that is awful how much they're going through every day. And all of that carries proteins and their vitamins, their minerals. So I tell them that is literally a parasite on you. We've got to supplement. You're losing your lunch through your legs. So we got to supplement. And they're trying to lose weight because everybody tells them to lose weight. Well, they're not going to because their body is saying you are losing everything. We've got to hold on to it so they can't. And they get really frustrated. So I think the first thing that we really need to do is say, okay, stop. You know, we're going to work on your nutrition. Don't be afraid to have this, 1,000-calorie drink. You need it. And you're not going to, gain, 100 pounds overnight, but this is the substrate that you actually need. I have so many morbidly obese patients that come in that are malnourished. They're malnourished. And so it's sad. And so, so the simple things, right? The simple things, like they can go to Walmart or Costco and buy a big case of the Premier Protein in a bunch of different flavors, and that will work for a large majority of our patients, and they can see immediate, almost immediate results from it. So sorry, kind of a long answer, but.
College place in Walla Walla County, family physician. Can you give us some comment on the use of Metrogel cream for wound care?
Metrogel?
Yes.
So I used to use it a lot on really stinky wounds. It's expensive. And being from Texas and training at Parkland and learning how to do all that stuff, we would just open a capsule of Flagyl and dump it on the wound. And it's like pennies on the dollar for the Metrogel. Maggots, if you're thinking about Metrogel, it's, I feel like it doesn't cover enough. It doesn't give me enough result. If it's super stinky, okay. I don't know, bright lights, cold steel, debride it a little bit. We've used it on some patients that had like enormous AV malformations that couldn't get debrided, or they couldn't get, the wound clean enough, and it was really smelly. But I feel like it's really expensive. And I don't know, I'm not that excited about it. But it's better than nothing. It's better than nothing. I think a capsule of open Flagyl and a little bit of, I don't know, antibiotic ointment, or I don't know. I feel like if soap and water is better than Metrogel. What do you think? Do you like Metrogel? You're right, it's going here. I don't know. Any other questions? All right, I'm dying up here. Thank you.